Welcome to the Lymphoma Research Foundation's update on oral therapies in lymphoma and chronic lymphocytic leukemia, small lymphocytic lymphoma. I'm Monica, and I'll be the operator for today's call. During today's call, you will hear from an expert speaker, and you will have an opportunity to ask questions. If you have questions during today's presentation, you can ask them at any time in the Q&A box on the webinar. As a reminder, this webinar is being recorded. At the end of the program, a link will appear on your screen. Please follow this link to complete an evaluation of this program. If you are listening by phone, this link will be sent to your email at the end of the webinar. And now I am pleased to introduce Jessie Brown. Jessie Brown is the Associate Director of Patient Education Programs at the Lymphoma Research Foundation. Welcome, Jessie.
Thank you, and thank you to each of you for taking the time to join us on today's update on oral therapies in lymphoma and CLL SLL webinar. I'd like to thank our sponsors of this webinar, AbbVie, AstraZeneca, Genentech, and Janssen Pharmaceuticals. Before we begin with the program, I'd like to share some information about the Lymphoma Research Foundation. We're the nation's largest nonprofit organization that focuses specifically on lymphoma, and our mission is to eradicate lymphoma and serve those touched by the disease. All our work is led by our Scientific Advisory Board, which is a group of 45 leading lymphoma experts from around the country. In today's program, we have a variety of other programs and services available to you. One example is our LRF helpline, which serves to complement our patient education programs. The helpline has master's level trained staff who provide individualized information on all types of lymphomas, as well as information on treatment options, clinical trial navigation, and connections to resources such as financial assistance. We offer a peer support program called the Lymphoma Support Network. Through the Lymphoma Support Network, we can connect patients and caregivers with others who have been through similar experiences for emotional support. In addition, LRF has free comprehensive disease guides and fact sheets, which can be ordered or downloaded on our website, lymphoma.org. We also offer a variety of other in-person and virtual educational programming, so you can continue learning about the latest updates throughout the year. And finally, we have an award-winning mobile app called Focus on Lymphoma. The app provides helpful disease content as well as unique tools to help you better manage your lymphoma. This app is available free of charge in the Apple App Store and Google Play. We have a wonderful program planned for you today with two expert speakers, and I'm honored to first introduce you to Dr. Michael Williams. Dr. Williams is a hematologist and oncologist at UVA Health. He's also the Bird S. Leavell Professor of Medicine and Professor of Pathology at the UVA School of Medicine. He is also a member emeritus of our Scientific Advisory Board. Thank you, Dr. Williams, for speaking at our program today. I will now turn the talk over to you.
Well, thanks very much, and thanks everyone for taking time out of your day to join us for what I think is going to be a very interesting discussion. So oral therapies in lymphoma, and you'll subsequently hear from Dr. Stevens in chronic lymphocytic leukemia, are relatively new, really within the past decade, and they represent an entire departure in traditional management away from typical chemotherapy that was used in the past. They often go by different names. Sometimes they'll be called, instead of oral, they'll be called targeted therapies or novel therapeutics, but they represent a new class of drugs that really work in a very different way from traditional cancer treatment. So what I'm going to do is just briefly frame how these are employed in the treatment of lymphoma. But just for a quick background, I'll remind you that lymphomas, the non-Hodgkin lymphomas, are a complicated group of diseases. There's well over 80 different types of the disease. Some of the more common ones are shown in this pie chart. And I'm going to really focus on the disease in red, mantle cell, which has been a long-standing interest of mine, both in research and clinically. And I'll mention a little bit about follicular lymphoma, which is a more common subtype, and how the oral therapies are now getting firmly entrenched in the management of those diseases. So this is a kind of a complicated slide, but it's really just a cartoon of a microscopic focus within our lymph nodes. This is called the germinal center, this purple egg-shaped structure here in the middle. And what this is to just inform you about is that, you know, our immune system is very complex, and it goes through a whole variety of stages that allows our immune system to respond to environmental pathogens, infectious agents, etc. On the T cell side, it helps with immune surveillance. But the cells that move through this part of the lymph node undergo a variety of changes. And during that course of maturation and differentiation, you can have mutations that arise just by chance. Most of the mutations that occur in lymphomas are not entities that are inherited from one generation to the next. They arise as an error in this cell proliferation. And depending on what stage of differentiation the cell is and the microenvironment that it's living in, then that can be expressed as different types of lymphoma. So you can see there's an area called the mantle zone, which is where mantle cell lymphomas tend to arise. You can see some chronic lymphocytic leukemias also arise from that area. So understanding the biology of all of these different subtypes really is a major focus of work, much of which I will say has been supported very effectively by the Lymphoma Research Foundation over the years. So we understand the diseases better, and that allows us to then find Achilles heels within these different types of lymphoma that we can target with these novel agents. So I mentioned I'm going to really focus on mantle cell because it gives a good view of how we're using these oral therapies. So just by way of background, this tends to be more common in men than in women, tends to be older patients in their 60s, 70s at the time of diagnosis, although it can occur in individuals in their 40s, 50s, rarely younger. Most people have advanced disease at the time they're diagnosed, usually represented by enlargement in their lymph nodes and the spleen, where the lymphoma cells tend to collect. Mantle cell is a little bit different from many of the other lymphomas in that it likes to go outside the lymph nodes, especially in the colon or other parts of the GI tract, sometimes in the skin or other soft tissue areas. Although it's a very specific subtype of lymphoma, it's very heterogeneous in that some patients have a very indolent, slow-growing disease that doesn't need treatment, often for months or years, whereas others have this blastoid variant that I mentioned, which is a much higher grade disease that tends to proliferate quickly and needs treatment with some urgency. So let's talk about how we use some of these newer therapies that can supplement or even replace traditional cytotoxic chemo. So when I say cytotoxic chemo, I mean drugs that work by killing cells by impacting their DNA or RNA. It cripples the cells so that they undergo cell death, but it comes with side effects of normal cells. For example, many chemotherapy agents will cause hair loss or sore mouth or low blood counts because of this anti-proliferative activity. But with the B-cell lymphomas, which are most lymphomas in the Western world, including mantle cell, one of the hallmarks is that the signaling pathway, the way the cell communicates with the external environment in the immune cell, goes through a series of enzymes, and that's shown in this cartoon with the BCR, which is the B cell receptor. So that's what recognizes, for example, a COVID infection or influenza or some other kind of exposure, and it tells these B cells to activate, make antibodies that will then destroy the virus in the cases I mentioned. So it does that through this whole cascade of proteins. The ones in red are the ones that are sort of turned on in different lymphomas and therefore targetable. And the way we target them is with this array of novel agents. The ones in red are already FDA approved for mantle cell lymphoma. Some of you may be aware that ibrutinib, up on the top left there, is a very widely used drug, very active and effective in mantle cell and CLL and other lymphomas. But recently, the indication from the FDA was modified, so it's still an approved drug, but not approved for mantle cell as it was before. So we have those drugs, and then down at the bottom left, you'll see venetoclax, which is a drug that works on a different part of the pathway, the one that allows cells to basically, it gives a death signal to the lymphoma cells so that they uh, basically disappear, and you get a good tumor response with that. So here's a list of the many agents that we use to treat relapsed mantle cell lymphoma, but they all have found use in the front line for previously untreated patients, as we'll talk about. So without going through these in any detail, the ones in the upper part, bortezomib, lenalidomide plus rituximab, you can see that in various studies, they have response rates from about 20% to 50 or 60%. And on the right column, the median duration of response. So how long does that treatment response last? You can see that it's under a year to maybe a year and a half or so. That changed about a decade ago when um, uh, ibrutinib and then other BTK inhibitors, acalabrutinib, zanubrutinib, and most recently pirtobrutinib, were studied and approved. And you can see the response rates are much higher, where the majority of people are showing a response. And you can see the durations of response in this relapse refractory setting is a year and a half or sometimes longer. And in fact, these are early numbers, and we have improved on these a great deal. So very active agents by themselves in the relapse refractory setting. So one of the things we've learned to do, this is work that's been done in our center and a number of others around the world, is looking at how you can combine these targeted drugs with one another, and they actually have synergistic activity. They work together to attack the lymphoma cells. And in this study, the blue arrow shows the use of ibrutinib, the BTK inhibitor. You give that for a month, and then you add in the drug venetoclax. And the reason it's got that little hazy triangle on the left side is that means we have to start the venetoclax slowly, so a very low dose, and over a period of 4 to 5 weeks, we increase it to the target dose of 400 milligrams. The reason we have to do that is that this combination is so potent at killing mantle cell lymphoma that you can get a massive tumor cell breakdown that can be cause very serious metabolic problems and even can be life-threatening. So we've learned to manage that with how we dose it and start it up. So this is just a quick example of the power of these targeted combinations. So this was a study from Constantine Tam and a group in Australia and Europe that was published a few years ago. So this was 24 patients with heavily pretreated and treatment refractory mantle cell lymphoma. They had high-risk features, including particular mutations that make them resistant to chemotherapy. Most patients had already failed intensive therapy and a stem cell or bone marrow transplant. And what they found is that they had very high response rates. Not everybody responded, but most had a very good and, in fact, a complete response. And in the curves here, you'll see on the left that a number of these patients are maintaining their response out to 2 to 3 years, although relapses are occurring. But importantly, and this has provided clues for ongoing and recently completed studies, that this combination is very effective in that 5 of these 24 patients actually went into complete remission to the point that they were MRD, or measurable residual disease, negative. And after about a year and a half, they were able to stop the treatment. And several of these have remained in complete remission for 6 months to up to 18 months off treatment. So that tells us that these people that had failed all standard and aggressive chemotherapies can get deep and durable responses to these oral agents. And that study and others led to this pharmaceutical company, Pharmacyclics, sponsored this international study called Simpatico, where they're comparing in relapsed patients the combination of ibrutinib and venetoclax versus ibrutinib and placebo to see what the benefit is for the combination versus just ibrutinib and then maybe use venetoclax at relapse. And they've expanded this to include people who had not had prior treatment. So as of this month, this study has still not been reported out. It completed its accrual. So we expect to hear in the next 6 to 12 months what the results of this have been. But this, if positive and it shows good safety and efficacy, then it could change the way we treat certainly relapsed patients, but maybe even people previously untreated. I mentioned that there's a lower risk, sort of slower growing type of mantle cell lymphoma, and this is a study from a group in Spain and the U.S. looking at ibrutinib plus rituximab for this indolent form. So rituximab, I'm sure many of you are aware, is an immunotherapy. It's not oral. It's given IV or by an injection under the skin. And without going through the details, they took this lower risk group of patients and treated them without chemo, just with ibrutinib and the rituximab immunotherapy. And you can see here that going out to 3 to 4 years and even beyond, that most patients have had very good responses. Their responses are continuing out beyond 3 years, and many of them were able to come off treatment after a short period, relatively short period of time, 2 years on the combined treatment. So again, very promising for moving away from chemo and using targeted drugs with immunotherapy. And again, I won't go through the details. It'll be in the slides that you'll get. But the U.S. intergroup study, this is across the United States, mostly academic centers, but some community practices. This is the new study for patients that are older than 60 or 65 with previously untreated mantle cell, so newly diagnosed. And this is testing totally a BTK inhibitor, zanubrutinib plus rituximab with options for patients who respond or respond less well. So again, moving away from chemotherapy in what would change practice if the study shows good outcomes. One other combination I wanted to mention is a drug that wasn't on my earlier slide. This is called lenalidomide. So lenalidomide is widely used. It's been available for many years. It's a standard in multiple myeloma, but it's also very active in a variety of B-cell lymphomas, including mantle cell. And Dr. Jia Ruan at Weill Cornell Medical Center published a study several years ago of older patients. They mostly had other health problems that made it difficult to treat their mantle cell lymphoma. So she and her colleagues used this combination of oral lenalidomide plus rituximab immunotherapy, and they saw a very high response rate, the overall response rate above 90%. The majority got a complete remission by PET scan and bone marrow biopsy. And you can see with follow-up at 3 and 5 and most recently 7 years that most of those patients are staying in remission. Some of them have come off treatment, and the survival is really quite good for this older population of patients with mantle cell lymphoma. The toxicities were manageable. This is a regimen we're used to utilizing. So very active as initial therapy for mantle cell. Just in the last couple of slides, I'll switch to follicular. So looking at the same regimen of lenalidomide and rituximab. So there was a study done called Relevance. So this was len and ritux versus standard rituximab and chemotherapy in patients with advanced stage, previously untreated follicular lymphoma. And you can see in the second bullet, they got either, it's called R2 or R squared, so Revlimid or lenalidomide plus rituximab versus chemotherapy regimens, R-CHOP, rituximab bendamustine, rituximab CBP. And then they got 2 years of maintenance rituximab. About a third of patients didn't complete all of the treatment, meaning induction and maintenance. Most of those were because the disease progressed on one or the other regimen or because of toxicities. But ultimately, there was no difference in treatment response when they did relapse on whatever the next line of therapy was. So it was comparable to chemo and safe, and you can really see that in these curves. So if you look at progression-free survival, so this is people living without the disease recurring, and the overall survival for these patients, which was above 90% going out to about 8 years, you can see that chemotherapy was basically no better than the lenalidomide rituximab. So very promising as an approach for follicular lymphoma to use a non-chemotherapy regimen. Non-chemo doesn't mean without side effects, because all of these drugs have side effects that have to be managed, but they're typically milder and different from the ones we see with traditional chemotherapy. So that's a quick introduction to oral therapies in lymphoma, and I will stop there and hand it over for Dr. Stevens to be introduced.
Great. Thank you so much, Dr. Williams. As a reminder, we'll take all questions at the end of the program. And I'm now honored to introduce Dr. Deborah Stevens. Dr. Stevens is a hematologist and oncologist at the University of Utah Huntsman Cancer Institute, where she is also an assistant professor in the Division of Hematology and Hematologic malignancies, as well as an expert in CLL, SLL. Thank you so much, Dr. Stevens, for speaking at our program today. I'll now turn the talk over to you.
Thank you so much for the introduction. And, that was such a great talk, Dr. Williams. And I think that was really nice for me because it nicely sets up some of the things that I'm going to speak about. I think I have just a little bit easier job because I have a narrow part of the lymphoma cancers to cover, and that's chronic lymphocytic leukemia or small lymphocytic lymphoma. And the things that I'm going to talk about today are the current oral treatment options, including management of the side effects, and spend a few slides talking about new and emerging treatment approaches. And again, a lot of these treatments have already been very nicely introduced by Dr. Williams. So first, I'm going to start out with an overview of CLL. And so what exactly is CLL? And you might have heard me say this is chronic lymphocytic leukemia. And we talk about this in combination with lymphomas because it behaves much more like a lymphoma than it does like the other types of leukemia, like the acute leukemias. So when you think about all of the blood cells, you think about red blood cells. They help to carry oxygen. If you have low red blood cells, that's anemia. If you have platelets, these are the cells that help your blood to clot. And if you have low platelets, that's called thrombocytopenia. And you have this whole group of white blood cells, which are supposed to be there as an important part of your immune system to fight infections. And CLL is a cancer of a type of white blood cell. And I've pointed out all the different types of white blood cells here and just highlighted the small lymphocytes. These are normally supposed to be cells that help fight infection, especially viral infections. And what happens is at some point in the development of this cell, a mutation usually happens, and this causes the cells to grow more rapidly than normal cells, and they don't die off. Normally, we would make our blood cells, use them, and recycle them, and make new blood cells. But these cells just kind of keep growing, and then they can collect in places like the lymph nodes or the spleen. So what's interesting about CLL as opposed to, Dr. Williams talked a bit about mantle cell lymphoma, and almost always for mantle cell lymphoma, we have to treat mantle cell lymphoma right at the beginning when we diagnose it. But for CLL, we only treat if there is active disease. And what we define as active disease is if patients have anemia or low red blood cell counts, that would indicate a hemoglobin of less than 11, or low platelets, which is defined as platelets of less than 100. If the patients have symptomatic enlarged spleen or lymph nodes, that might be a reason to treat the CLL. Or we talk about these B-type symptoms, and that might be a significant amount of weight loss. That's 10% in the last 6 months. fevers when you don't have an infection, or drenching night sweats when you don't have an infection either. And then severe fatigue, is sometimes hard to sort out from other causes of fatigue, but it can be an indication to treat CLL. And so the folks who are not treated for their CLL, we a program called Watch and Wait, and sometimes people talk about that as watch and worry, and that is because sometimes it makes people a little bit nervous not to treat an active leukemia. But the reason why we don't give early treatment is because there have been multiple clinical trials over time, and none of the treatments when given early have yet been proven to lengthen survival. I just want to note that I'm going to be talking about a trial that looks at early intervention a little bit later in this talk, because I don't think we have fully trialed all of our new regimens. And there's a potential that with the limited toxicity of these and the high response rates, we might be able to cause people to live longer by giving earlier treatment. But that's under active study right now. And when we treat CLL, we have to have kind of realistic approaches of what are the goals. And as of right now, there's no cure for CLL except for the setting of bone marrow transplant, and that is pretty involved and can be pretty toxic procedure. So not all patients are candidates, and we wouldn't recommend that for all patients with CLL because of the high level of toxicity. And so our main goal with treatment is to put patients into remission. And remission doesn't mean cure, but it means we can't detect any evidence of active CLL. And we want to do that for the longest time possible. And so you may hear your doctor talking about these terms, or you may see them in your clinic notes afterwards. And we talk about things like complete remission, meaning the blood counts are completely normal, lymph nodes and spleen are normal size, or partial remission, meaning there's been at least a 50% reduction of lymph nodes, lymphocyte count, or spleen after starting therapy. Stable disease means no change, or progressive disease means that there are new areas or worsening areas of disease. So I want to look at the most current oral treatment options for CLL right now, and these are referred to as targeted therapies. We used to talk a lot about just general chemotherapy, and chemotherapy are drugs that typically go in through the vein, and they can go in and they attack normal cells, they attack the cancer cells, and then your body's goal is to repair the normal cells to come back. But with the targeted therapy, the point is to try to avoid killing any normal cells, which is where a lot of the toxicities from chemotherapy come from, and really focus and go after the cancer cells. So drugs that are used, and I'm really going to be focusing on drugs like ibrutinib, acalabrutinib, zanubrutinib, or venetoclax that are the most commonly used targeted therapies and oral therapies for patients with CLL. So first we have a group called Bruton tyrosine kinase inhibitors, and Dr. Williams really nicely introduced this, and he showed the B-cell receptor pathway. And how I think of it is that B-cell receptor pathway is that's kind of what makes the cancer go. So it helps the cancer cells to divide and grow and survive. And so what I think of blocking this pathway, and BTK is a really important part of this pathway, so it makes sense to block it. I think of it as like taking the gas out of the car. So, once you take that away, your cancer cells can't grow, divide anymore. So these class of drugs, they're called ibrutinib, acalabrutinib, and zanubrutinib, and they're all approved currently for the treatment of all patients with CLL, so front line, second line, whenever you need it. Dr. Williams touched on this a little bit, but I wanted to really focus on the toxicities, because those of you who have taken these drugs know that there are toxicities with these drugs. Although they're much better than our old chemotherapy drugs, they still can be bothersome on a day-to-day basis. And one of the reasons why they can be particularly bothersome is these drugs are meant to be taken indefinitely, and that means there's no set end date for treatment. So when you go on them, I usually tell people you're going to take it unless you have side effects that need to come off, it's not working anymore, or something else better comes along that we decide to change you to. And so I tend to group these side effects into early, later, and side effects that can come at any time. So it's always a risk. So early toxicities I have highlighted in gray here, and they can be joint pains, infection, sometimes diarrhea. With acalabrutinib, you can get headaches as well. And these usually go away within the first couple of months you're on treatment. So, if you can tolerate it for the first month, I'll talk about some management strategies as well, but they will go away over time. There are a few things that are important to note that do increase with time, and they're in the light blue color, and that's atrial fibrillation or an abnormal heart rhythm, and hypertension or high blood pressure. So these are things your doctor should be asking you about. Are you having fluttering of your heart, palpitations, and checking your blood pressure to make sure that this side effect isn't happening to you. Something that can happen at any time with these drugs, it's consistent across all the drugs in this class, is bleeding and bruising. So the bruising happens, you might just note you bump your arm into something and it's just a way easier to bruise, and the bruise is bigger than you would expect before being on the drug. And it's really important to note this, like, for example, if you're planned for a routine surgery, like let's say you need to have your knee replaced, you need to tell your surgeon that you're on one of these drugs, because they're going to want to hold that drug before surgery and after to limit your risk of bleeding. And unfortunately, this side effect doesn't really get better with time. It's notable that there have been some head-to-head studies comparing ibrutinib with acalabrutinib or ibrutinib with zanubrutinib, and all of these side effects seem to be less, with the exception of the bleeding and bruising issue. There are a couple of easy management techniques. These are the early toxicities that I mentioned, the joint pain. Usually Tylenol is better to use than ibuprofen, because ibuprofen can also cause some issues with bleeding. Or if it's really bad, you can do a short course of oral steroids, have your doctor prescribe that. The kind of muscle cramping or myalgia, hydration is very important, stretching, pickle juice or other things that are kind of high in sodium, magnesium supplements. Sometimes my patients tell me that those help. And then diarrhea, as long as it's mild diarrhea, you can use an anti-diarrhea medication after clearing it with your doctor, because they may want to check your stool just to make sure you don't have infection. And if you're having more than 7 episodes in a day, that's considered severe, and you should be evaluated either in the clinic or in the emergency room if you're having that severe of diarrhea. I mentioned that acalabrutinib has a little bit more likelihood to have a headache, and this can be treated with Tylenol or caffeine pretty effectively. Again, side effects should get better after you're on the drug for a couple of months. Managing the later toxicities are a little bit harder. The atrial fibrillation often requires a consultation with a heart doctor, requires medications to slow the heartbeat, maybe blood thinners. Please don't use warfarin or Coumadin in combination with these BTK inhibitors, because it really increases your risk of bleeding. These are all things that should be managed by your cardiologist. And before you start any new medication, please check in with your oncologist, because there are some drug interactions with these drugs, and you just want to make sure that you're not decreasing the effectiveness of your cancer therapy or putting you at risk for higher complications. And then hypertension, unfortunately, a lot of times we have to add some additional medications to manage the blood pressure if it gets too high. And then again, I mentioned with the bleeding, make sure you let your surgeons know if you're on one of these drugs so they can recommend holding before elective surgeries. If you have to have an emergency surgery, it's an emergency. Just do it. We'll figure out the bleeding later. This can be remedied by transfusing platelets, even if you have a normal platelet number. So just note, again, drug interactions are always possible. So before you start on a new drug by any other doctor, please consult with your cancer doctor. The other important class of medications in the treatment of CLL are drugs such as venetoclax. These are drugs that inhibit something called BCL2. And so how I think of this is that CLL cells want to increase this BCL2 protein because it helps them to live longer. They want to do anything they can to survive. But if you block that with a drug called venetoclax, it tips the scales towards cancer cell dying. And so venetoclax is approved for all CLL patients. It's usually given in combination with immunotherapy, anti-CD20 antibodies called rituximab or obinutuzumab. So important things to know about venetoclax, I find that it is generally a very well-tolerated medication, but right at the beginning you could get something called tumor lysis syndrome, and essentially the premise of this is the drug works well and it works very fast, and all the cancer cells die at once. And so you have to make sure you're really hydrated so your kidneys can help get rid of all those waste products that come out. If you have really bulky lymph nodes or very high white blood cell count, you might even need to be hospitalized before starting this drug, and that's something your cancer doctor should be thinking about before starting one of these treatments. These drugs can also cause diarrhea and nausea. Anti-diarrheal drugs like Imodium can be used, nausea medications. Sometimes I find my patients say that if they take their dose at night, that helps them because they're already kind of sleeping through the nausea part anyway. So that's usually pretty easily managed. You can have low infection-fighting white blood cells, which are called neutrophils or platelets, and so your doctor is going to monitor those. They might need to give you some shots to boost up your white blood cell count called growth factor injections. And then infections and these venetoclax in the combination with rituximab or obinutuzumab really can cause you to get infections or have a lack of vaccine response. And so I typically don't give a lot of vaccines when my patients are taking these drugs. I wait for them to be done with the treatment. One thing that is nice about these treatments is they're time limited. So in the frontline setting, you get a year of treatment. In the second line or subsequent line of therapy, you get 2 years of treatment, and then they stop. So you can kind of think of that, if you're thinking about getting a vaccine like the shingles vaccine, which is kind of, you get the 2-shot series and it's a one-time ever. I wouldn't recommend doing that while you're on this treatment. Wait till it will work a little bit better. So you can see that we kind of have a couple of different strategies. We're either doing this continuous therapy with the BTK inhibitors with the goal of having prolonged remission, disease control, or we're doing these fixed duration with drugs like venetoclax and obinutuzumab or rituximab. And the goal of that is to try to cause such a deep response that you can have some time off of therapy. And we do talk about undetectable minimal residual disease, which essentially means that we've put you in such a deep remission that we can't even find any CLL cells anymore. So I'm going to highlight now just a couple of new treatment options. I'm sure there'll be questions about this because I can see some people are interested in these drugs anyway from the questions. First, I would just want to talk about early treatment because I mentioned that I would talk about this. As of right now, people who don't have symptoms from CLL are put on this watch and wait program, but this particular clinical trial is for newly diagnosed with CLL, and that means you've been diagnosed within the last year, and you have some sort of high-risk feature. So that might be you have deletion 17p or a TP53 mutation, or you have a combination of clinical and genetic risks that can be calculated by your doctor. Basically, what we're doing here is we're enrolling people with high-risk, newly diagnosed CLL to either doing treatment right away with venetoclax and obinutuzumab or waiting until our standard, which would be developing symptoms. This study is ongoing, and so if you feel like you might qualify, the Lymphoma Research Foundation team certainly can help you get in touch. It's open at most centers across the country and even some centers in Canada right now. Also nice because this study does pay for the treatments, whether you're on the immediate treatment arm or the delayed treatment arm. So that's an exciting new way to figure out if early treatment might help to make you live longer. So what happens when these great drugs like the BTK inhibitors don't work anymore? So what really happens most commonly is the drug binds to a spot on this BTK, and that spot can mutate to try to get around the killing of the cancer drug. However, and so basically it still kind of binds, but it just doesn't fit very well. So I think of it as like a key, like maybe it can fit in the hole, but it's not fitting very well. And so basically some of your disease is under control. And so what you usually see when this happens is just kind of a slow creep up of your white blood cells or a slow increase in your lymph node size. And what's really important is even if you think it's not really working, don't just stop the treatment without telling your doctor, because the CLL that was being controlled by the drug is going to get a lot worse very quickly. So don't discontinue without another plan. This applies to ibrutinib, acalabrutinib, and zanubrutinib. And so what's really exciting is we have these new drugs that are coming into play that don't require that binding site. So Dr. Williams already mentioned pirtobrutinib, and there's this really big study called the Bruin study that looks at a lot of patients that had subsequent treatment for CLL, so 252 patients, and were treated with this pirtobrutinib, which is an oral BTK inhibitor. Really great overall response rate, almost 70%. That progression-free survival was not reached for at least a year and a half, even for people who had 3 or more than 5 prior therapies. Progression-free survival was actually exactly the same, even if you had one of those BTK mutations that I just talked about. And what's really important, there's pretty minimal side effects of this drug. It's be a real game changer. It has not yet been approved for CLL, but it's been approved for mantle cell lymphoma. And so I know that they're working on a lot of studies that might help it to get approved for CLL. So know that it's just a drug to watch. There are a lot of combination studies that are ongoing, and it's not quite available yet outside of a clinical trial. There's a similar drug called nemtabrutinib that is also undergoing study. Not quite as many patients on this study as the last one, but great overall response rate, 53%. Responses in patients who had previously received another BTK inhibitor. A little bit more side effects than the pirtobrutinib, but not a lot. Most common fatigue, constipation, a little taste disturbance, or cough. And so this is another drug that's really important to watch. And longer follow-up, the study will tell us, who are the best patients to use these drugs. Again, this is another drug that's only available on clinical trial, not quite available yet. The last new treatment that I want to talk about is CAR T-cell therapy. This is basically the concept of it is your own immune system, you're training it to fight the cancer and activate your immune system. And so what it looks like is this is a very rough schema. Basically, you get your blood collected, part of your immune system, the T cells are separated out. In the lab, they are trained to go after something on the surface of the cancer cells, which is usually CD19, but there's a lot of other things in study right now. Once you have this great T cell, you ask it to multiply in the test tube, and then coming back to the patient, you get chemotherapy and the CAR T cells are infused back in. And those T cells go out. You just created an army of T cells in your immune system to directly fight the cancer. This does have side effects, including overactivation of the immune system, which can be fevers, low blood pressure. It could be very extreme. Be monitored very closely during this process. And, there's still ongoing data coming out about this, trying to figure out who are the patients that are going to respond the best, who's going to be the best candidate, meaning who can tolerate the toxicities. And so I think, lots of really great things going on in the field of CLL and generally non-Hodgkin lymphoma. I hope I've covered some of these treatment options, including the side effects and a few management strategies, and just talked about a few of the new and emerging treatment approaches. And so now I think we're going to move into question and answer time.
Great. Thank you so much, Dr. Stevens. We'll get started on Q&A shortly, and we'll get to as many as possible. If your question is not answered, we apologize, but you can always reach out to our helpline or email us at helpline@lymphoma.org, or you can review the presentation once it's sent to you following the program. So to start our questions off with, I'll start with Dr. Williams. Do you recommend any prophylactic meds for those on maintenance rituximab? Only side effects so far is pinpoint rash with itching.
Thanks. We typically do not use prophylactic antimicrobials for bacterial or viral infections. There is an increased risk of getting certain infections in people on maintenance. Most commonly, those are upper respiratory infections, sinusitis, bronchitis, etc., that can occur after some months on the maintenance. Depending on where they are in the course of treatment, we may just say, okay, we're going to stop with a year of maintenance instead of longer. Or other times we'll give intravenous immune globulin, IVIG, to help mitigate some of those respiratory infections. And keep in mind that all of these medications, in addition to the immunocompromise that kind of comes with the disease of the immune system, like lymphoma or CLL, puts people at more risk. And we certainly saw that during the COVID, uh, the peak of the COVID epidemic, where folks that had these diseases and got infected tended to have more severe or sometimes even fatal infections. So that's sort of where we are with prophylaxis on Ritux.
Great, thank you, Dr. Williams. Dr. Stevens, is maybe I'm pronouncing this wrong. Is petaGI considered an adverse side effect for a CLL patient on acalabrutinib, where this patient has all blood counts back into normal range, including platelets?
Yeah, and it's pronounced petechiae, and that's kind of the medical term that we use for. And so I touched on this a little bit. It is a side effect on acalabrutinib. It's a side effect for all of the BTK inhibitors, and it's not directly related to the platelet count. And the reason why is what it does, on real molecular level, it inhibits the platelet binding to something called von Willebrand factor. And so you can have a completely normal platelet number and still have the bleeding and bruising. And that's why, I recommend making sure that if you're having bleeding or bruising issues, to talk to your doctor about it. If you're doing a surgery, make sure that you're telling the surgeon about it. And what happens is it inhibits that interaction there between the platelet and the von Willebrand factor, which helps clotting. But if you need to, you can actually transfuse new platelets because they haven't been inhibited yet, and that will help to stop the bleeding if there's an emergency. And so it's not correlated to number of platelets, it's platelet function that is impaired.
Thank you, Dr. Stevens. Dr. Williams, someone asked, is pirtobrutinib an effective bridge after failure of zanubrutinib before beginning CAR T-cell therapy?
Well, it can be, and bridging therapy is important when you're considering the use of a CAR T, because it takes typically several weeks to maybe a couple of months or more to generate the CAR T that's going to be infused. And during that time, the disease could be progressing. So you need to control it so that you have as good a control of the disease as possible when you give the CAR T. So pirtobrutinib is one of the options in mantle cell lymphoma. Patients who have been exposed to a BTK inhibitor like ibrutinib, acalabrutinib, zanubrutinib, and they're showing resistance to that, then pirtobrutinib will provide a response in about half of those patients. So you can give that a try, but if patients aren't responding well, then you may need to shift to an alternative class of drugs rather than a BTK inhibitor.
Thank you. Dr. Stevens, someone asked, is there one blood test to track for CLL progression to indicate a need for treatment?
This is a great question, and unfortunately, there's no one thing that is going to indicate need for treatment. So we often, I'm sure your doctor is checking your blood counts every time, and we do pay attention to the white blood cell count, but there's no specific white blood cell count that indicates a need for treatment. It's more based on, let's say, if you're anemic, and maybe your hemoglobin was 14, and now it's down to 12 and maybe going down to 11. So anemia might be a reason to treat the CLL. So that's a hemoglobin that you're tracking. Or platelet counts. So same thing with platelets. If we're seeing a downtrend in platelets, maybe it used to be 150 and now it's 100 and then it's down to 75. That might be an indication to treat CLL. But we have to put it into all together with symptoms, because if you're not having any symptoms and all we're doing is fixing a lab value on your routine blood draws, that's not what we're interested in. We're interested in helping you live your life better, so get rid of symptoms. And so if there's absolutely no symptoms and all we're seeing is a lab abnormality, even with the hemoglobin or platelets, we might do some other tests just to make sure there's no other reason. Sometimes people get autoimmune problems with CLL, and so you can get into a situation where your immune system thinks that your like your red blood cells or your platelets, are like bacteria and tries to get rid of them. And so that might be something we might just need to treat that condition with a little immune suppression like steroids instead of fully treating the CLL. And so it's really important kind of putting everything together so there's no just one blood test that you can look at. And I think the most important thing is, how do you feel? If you're feeling well and living your life, most likely you don't need treatment, or at least you don't need urgent treatment.
Thank you, Dr. Stevens. Dr. Williams, can those taking maintenance rituximab for 3 years for mantle cell lymphoma then go on to use rituximab again, say in combination with lenalidomide when relapse occurs?
Yes, certainly can. You might expect that if you've been off your maintenance, let's say you finished it a year ago and now you're having disease progression, then maybe you'll respond a bit better when rituximab is restarted. But because lenalidomide and rituximab have synergy when given together, the lenalidomide enhances the efficacy of rituximab, plus it has its own anti-lymphoma activity, then you can get the combination and still get a very good response.
Thank you. Dr. Stevens, will there be any inclusion of the treatment on the development of MDS?
I'm not sure exactly what this question is getting at, but just for everyone, the MDS means myelodysplastic syndrome, and that essentially means a scarring of the bone marrow that can go on to turn into acute myeloid leukemia, which is a more severe and aggressive subtype of leukemia. And so I don't know if the question is, are any of the treatments that we've talked about people to the development of MDS. And, thankfully, at least in CLL, the oral therapies have not been associated with the development of MDS. Our older chemotherapy drugs like fludarabine and cyclophosphamide and, sometimes bendamustine have been associated with the development of MDS. This is usually common in as much as 5% of patients, and how you would determine if you have it is your doctor would look at your blood counts, and if you have a lot of anemia or low platelets that's not explained by the CLL, they might have to do a bone marrow biopsy to take a look and see if you have MDS. So I'm not sure if that totally answers the question, but that's a general rundown on my thinking of MDS in this field.
Great, thank you. Dr. Williams, someone said you mentioned the zanubrutinib trial that's about to start this summer. Where would this person find info on that?
Yeah, great question. So that was the zanubrutinib trial for mantle cell lymphoma, previously untreated. So it's a good question because it lets us remind you that basically any clinical study for cancer being done in the United States, you can find on clinicaltrials.gov. So all of them are listed there. And so you can find those that are in development but not yet open, and whether they're accruing new patients. So that's the site to go to. It's managed by the National Cancer Institute. So very reliable source of good information.
Great, thank you, Dr. Williams. And if anyone has any trouble on that site, they can always reach out to LRF's helpline too, and part of our helpline team can help you navigate that site as well. Dr. Stevens, when would you use the combination BTK inhibitor plus CD20 monoclonal antibody?
This is a great question, and the answer is slightly if we're talking about non-Hodgkin lymphoma than CLL. But in non-Hodgkin lymphomas like mantle cell and other subtypes, very often when we use a BTK inhibitor, we're going to be using the CD20 combination. But specifically for CLL, most of the time, I actually don't use the combination together. Let's say we're planning a frontline therapy for someone, and with ibrutinib and zanubrutinib, there's not a lot of good data that give us reason to give the CD20 monoclonal antibody. With acalabrutinib, there was a study called the Elevate treatment naive study that compared acalabrutinib versus acalabrutinib plus obinutuzumab, the CD20 monoclonal antibody. And actually with longer follow-up, I think the follow-up's about 4 to 5 years now, and it does look like people in remission longer if you use the CD20 monoclonal antibody up front. So the reason why I haven't kind of jumped on and given it to everybody is because I do think it adds some toxicity. It requires you to come into the infusion suite. You get an additional 9 infusions. And so this also kind of cuts down your ability to respond to vaccines. And, if it's not absolutely necessary, then I don't give it. And times when I think it's necessary are people who need a very fast response. So let's say their CLL is progressing pretty quickly, because it often takes us some time to get insurance approval on the oral pills. So I can always start with a CD20 monoclonal antibody. Or if you have that condition, that autoimmune condition where your body is breaking down red blood cells or platelets, it's called autoimmune hemolytic anemia, or ITP in the case of platelets, helps up front to give the CD20 to get that under control pretty quickly. And so I think really it's best used in combination if you need a really fast response and you're having a delay until getting the BTK inhibitor approved, or if you have autoimmune complications.
Thank you, Dr. Stevens. Dr. Williams, someone had asked just how nutrition is implemented during treatment and afterwards, and if you have any recommendations for this person.
Yeah, in general, for these diseases and these therapies that we've been discussing today, there is no particular dietary regimen or modifications that need to be used or are recommended. I always tell people a good heart-healthy diet is a good idea in any setting, including these. I would caution people about the use of nutritional supplements or naturopathic remedies and things, because those things are not regulated by the Food and Drug Administration, and what's in them is not consistent necessarily from batch to batch, or even with what might be effectively on the label. And Dr. Stevens made a very important point that there can be a lot of drug-drug interactions, and so some of these supplements might actually interfere with the benefit of the treatment that you're on for your lymphoma or CLL, or alternatively might add to the toxicity. It might worsen, say, the bleeding or some other risk. So we recommend, staying away from those as well. And Dr. Stevens may have some other comments to add to that.
Yeah, I totally agree with that. I think at least for CLL, the two things that have been studied most in terms of dietary supplements are green tea extract and curcumin. And it was a nice study, and it looks like it does help people's white blood cell counts to go down. However, unfortunately, the volume, the dose that you have to take actually causes some toxicity. So it causes diarrhea and nausea. And so it's not just like drinking a cup of green tea every day. It's like drinking like 40 cups of green tea every day. And so the amount that you have to take, is not worth it, because in my opinion, because once you stop taking the supplement, the white count goes back up. And I don't think there's really a clinical benefit to doing it. And outside of that, I haven't seen any other studies that I thought were nicely done that provide any support to using supplemental therapies.
Thank you. And Dr. Stevens, is AFib side effect permanent, or will it go away when the treatment is completed?
This is a good question. I think most of the time I see that AFib becomes a permanent thing. Unfortunately, that's most common with the BTK inhibitors, which are meant to be a chronic therapy. And so, if the CLL is responding really well, there's not a good reason or a clear reason to stop that drug because people develop atrial fibrillation. I find that if it's intermittent, which means it comes and then it goes, it comes and goes, it seems to be more frequent and more pronounced when you're still on the BTK inhibitor therapy. And then what happens when you have atrial fibrillation is it puts you at risk of stroke. And so most people need to be on some sort of blood thinner. So you're on a blood thinner, and the BTK inhibitor makes you bleeding. And so, it can get into some more heavy bruising or bleeding problems. And so most of the time I find that it becomes a problem that doesn't go away.
Thank you, Dr. Stevens. I think we'll try to fit in 2 more questions if we can, one for each of you. Dr. Williams, do you envision oral therapies for Hodgkin lymphoma in the near term?
Unfortunately for Hodgkin lymphoma, I don't. There's a lot of exciting progress in managing that disease. The frontline therapy is evolving to be even more effective, but none of those will, in general, at this point, involve oral agents for the majority of patients with Hodgkin.
Thank you. And for our last question, Dr. Stevens, someone said, I'm recently off venetoclax after nearly 3 years, in remission for over 2 years per PET scan. My blood counts have not recovered. How long would I have to wait before becoming concerned with these impacted blood counts? And this is a CLL SLL patient.
Yeah, I do see that. That is one of the common side effects that I mentioned, and sometimes they can be pretty prolonged afterwards. It depends on the degree of the blood counts. So, if the good white blood cells are down, and that could put you at risk of infection, and so your doctor should be doing growth factor injections to boost those up. If you're requiring transfusion of platelets or red blood cells, by this point, I would always recommend doing a bone marrow and just make sure that it is venetoclax toxicity and there's not something else that's going on in the bone marrow that's keeping the counts from recovering. And so if you haven't had a bone marrow biopsy yet, depending on the severity of the counts, it might be something to talk with your doctor about.
Great. Well, I'd like to thank both of you so much for joining us on today's call. We had a bunch of interesting questions, and for anyone who wants to watch this session again, just as a reminder, it'll be sent to you via email. We'd also like to thank our sponsors, again, AbbVie, AstraZeneca, Genentech, and Janssen Pharmaceuticals for making this program possible. Please remember, if you have any additional questions, you can always reach out to the LRF helpline at 800-500-9976. And we'd like to thank everyone so much for joining us today, and we hope you all have a wonderful day. And thank you again, Dr. Stevens and Dr. Williams.
Thank you.
Thanks, everybody.